this is Roger Green, host of the Surfing the NASH Tsunami podcast. Today, we're offering 4 conversations from episode 31, our kickoff of a month-long review of the changing landscape we all saw at EASL Congress 2023 and the American Diabetes Association Scientific Sessions, my one-to-one conversations with Mazen Noureddin and Jörn Schattenberg. This conversation constitutes the second part of my interview with Mazen Noureddin. We continue to explore the question of what we do and do not know about the different mechanisms of action for MASH drugs and the commercial implications. Along the way, we expand on Mazen's monopoly metaphor, discuss why Big Pharma is like Hollywood, and emphasize why it is so important to move beyond ordinal histopathology reads in the drug approval process. Finally, we look into all the elements of what promises to be a very exciting future in fatty liver disease. Our entire key opinion leader and advocate team has been struck forcibly by how many studies provided significant advances in knowledge and how some of these advances might change our underlying appreciation of drugs, diagnostics, artificial intelligence, machine learning, and how we think about fatty liver disease overall. It's quite a lot to digest and very exciting to consider, so sit back, listen, learn, enjoy. When you're done, join the dialogue on our LinkedIn discussion group. So the only other thought I had listening to you was my favorite moment in the Maestro NASH presentation was someone asked Stephen about liver volume, and his answer was, yeah, there's a liver volume effect here. We don't know exactly yet what it's related to. It may be inflammation, but you couldn't predict the amount of liver volume change simply based on the metrics that we know how to use. So I think there are things we just don't know about yet, right? There's what we know, there's what we don't know. To change metaphors, the sun is starting to break through the clouds, but it's still pretty dark and soupy out there, and there's a lot that we've yet to see.
Mazen Noureddin.
Yeah, and I'll throw an example. What would TH beta does with GLP-1? What would it do with FGF21s? Would the fibrosis be different if you had these combination? As you know, resmetirom has achieved very significant endpoints despite the biopsy hurdles. We had NASH resolution, we had fibrosis improvement, we had both, and NITs moved the same directions. So that was outstanding. At the same time as the Bicosofirmin data was presented and was published in the New England Journal or appeared online during the meeting, which was cool. And we started hearing other questions. Is people trying to compare Bicosofirmin to Efruxifermin? And indeed, there are actually other FGF21s in the pipelines. For example, Boston Pharma, they have a very attractive FGF21 that is probably going to be less frequently injected. And the question in the future, we're going to compare across this class in terms of GI side effects as well as the antibody formation story is not out yet. So especially if you use it for a longer time. So we'll see that in the future as well. But what I want to mention about the Bicosofirmin versus Efruxifermin, there were multiple questions, which one is better? And I think this is really, I want to caution people really hard on that comparison. I want to remind people an example of obeticholic acid. When it came out first initially, it showed NASH resolution, which did not show in the follow-up studies. So having these two drugs and trying to put the figures next to each other and try to calculate the delta and which delta is better, and I caution people to do that. Look at the drug, look at its specificities, pegylated or not pegylated, GI side effects within that drug, but we really cannot make final decision which more is more efficacious than the other unless if we could do a data comparison. I mean, a lot of people say Efruxifermin is more effective because of that higher bar. The other people is the delta, and look at that. So I caution people to look at that.
So Mazen, here's the other complication. While we're throwing metaphors, I love monopoly. I hadn't heard it before, but one I've been using for 20 years in different settings is that it's best to think of Big Pharma these days as being like Hollywood. Hollywood has basically stopped making creative movies, but they're so strong at marketing and distribution and finance that after you've made your brilliant creative movie, you need Hollywood to get it to 200 screens in America on the same weekend and nominated for Academy Awards and all that. But what Hollywood really likes most is sequels. So they don't know how to value the first property, but they do know what Rocky 7 is going to be worth as compared to Ant-Man 4, right?
Okay.
So if you think of that in the Big Pharma context, what people are trying to do right now is value new properties because we don't have Rocky yet. Forget Rocky 7. We don't have Rocky. We don't have Star Wars. We don't have any of those things. And people are trying to figure out, so which is the franchise that's really going to work? And it leads to exactly what you just described, which is, now we'll take all these metaphors together. So I've now decided as a commercial guy that the property called FGF21 is really valuable. Maybe that's Boardwalk and Park Place. Maybe. Okay. But then I have to decide which one is Boardwalk and which one is Park Place. And I don't really have a way within the class to make that comparison because we don't know yet. But the bet I'm about to make is tens of billions of dollars if I'm going to acquire a company. So that's really easy if I've got to value Rocky IV off Rocky III. It's very hard if I have to value Rocky I, as compared to some other movie that looks the same in the script but turns out to be a complete bomb.
Yeah, if I understood you correctly, the only difference I see that, and I don't know if I misunderstood you, I think we do have novelties here and a lot of innovative drugs. Mm-hmm. How long we had diabetes and obesity for, and now we're seeing like things shaking. Like, you get 25% with, forget about discontinuation and nausea and vomiting. Someone can get to 25%.
If someone can drop 54 pounds in a year and keep them off if they stay on the drug.
We haven't seen that for decades. We have novel mechanisms. Like, you would think, well, the endocrinologists did think that TH-betas can do something. It was mainly directed to the lipids. And now, like, you have these innovative mechanisms that actually target the liver. And FGF21s, they came after, we looked at the 19s and now the 21s. So I think we have great steps, great innovations, like genetic therapies, not even touching base on them, like the HSD17 or PNLP3. We're still reading stories. So what I'm trying to say here is that it's an exciting time, really. Where I see that we took a lot of hit is the assessment that we have right now. Again, I'm not trying to point fingers to anyone, especially to the regulators. The regulators have to be objective and go with the best evidence, which is the liver biopsy. And our job is to show them, and we have been building the case. Like right now, if you go to the regulator and say, hey, Brunt and colleagues showed that ballooning cell is impossible to agree on. The inter and intra-observer variabilities are impossible. I think the answer is like, yeah, we do agree, but give us the evidence that we can move on and we can talk about that at another time. The novelty and the big movies, as you said, they're coming out. I think it's just the way we're assessing them. And I bet you in the future, once we move to the NITs as a valid way for assessment, and we're already seeing that you see more effect in the liver and other parts of the body rather than liver biopsy alone.
I want to have you back when we do this episode. We're going to do another episode later this month where if we can get it on your amazing schedule, I would love to have you join us. Because one of the things that struck me in the meeting completely off this point is that we use this phrase AI machine learning, and we use it to describe everything from what you can pull out of an EHR database to identify patients we should be screening that we're not, to how do we apply this to clinical trials, to what can we learn actually about the liver in terms of, which drugs affect which regions of the liver and how. And all that's available to us. We call all of it AI. We throw it into one bucket, and people get very confused when they use those terms also. It's like wherever you look on the landscape right now, there's a lot of progress and it's all still shrouded in fog. You know what I mean?
Yeah.
When we come back to this issue, we're going to do 1 or 2 drug development episodes this month coming out of the various conferences. One is going to be to take a look at what's in the short term versus what it might mean in the long term, right? We saw a really interesting FASN inhibitor presentation. We saw the first genetic medicine presentation, the alnylam Regeneron drug, and there's a long way to go on that. But I know, for example, I think it's AstraZeneca has a PNPLA3 target and HSN1713 target, both in mid to late stage clinical development. So all this stuff is going to start happening really fast, faster than people can keep track of it. And I guess when we put this episode together, one of the hopes was to dive into a couple of these issues specifically, FGF21 being one, the glucagon agents being a second, and then maybe cross-class comparisons being a third, and asking, so what do we really know now? And what do we think we know, but maybe we don't?
Oh, I can tell you it's really exciting.
Yeah.
I need to send you that slide, the Monopoly slide.
Which, if you have rights to it, we'll post on our website when we post this episode so everyone can see it. I guess the question I'm going to start asking, and it just came up as you and I were talking, is what does this mean to me if I'm evaluating drugs for investment? What rules should I be using right now to figure out what's worth investing in? And if I'm a clinician, what should I be getting excited about?
There's a lot to get excited about.
Yeah, it's the frightening thing, right? You get excited about all of it and just not know yet what's going to matter most.
Yeah, we have hopefully the first drug to be approved, hopefully by 2024. Mm-hmm. We have other drugs chasing that drug, that they look quite efficacious, like the FGF21s, the GLP-1s, and others. And there are also precision medicine coming on the way that you alluded to already.
And then, as you mentioned, there's PPARs. You mentioned that earlier. Their data's been pretty compelling, and they're in phase 3.
Yeah, the lanifibranor looks really good, and their trial is ongoing. And again, it's the glass half full. At the same time, we have this liver biopsies is holding us back, and we'll see how the future look like. But you can predict that with more data data that we're producing that the future of these clinical trials will be on steroids, or will be really fast once we get to the non-invasive testing. Like obesity trials, like they're much easier to do than a NASH trial. And we will get there. It's just we're showing the evidence. What the clinicians need to know is that everything comes with a price. We're paying now the price of liver biopsy and other things. And eventually these patients need to be managed. If you're losing 25% of weight that we have not seen in decades, there's a price for that, the nausea and vomiting and other GI side effects. And guess what? Those are GI doctors that they know how to manage that. They just need to get more comfortable with managing other medications, such as type 2 medications. And they don't have to do it alone. They have to do it with an endocrinologist.
Yeah, I was going to say, so the question Ken Kuzi always asks on our Rising Tide series is, when are my hepatologist colleagues going to start acting more like endocrinologists, start prescribing GLP-1s in the same way that they're asking endocrinologists to act more like hepatologists?
Yeah, I mean, we have done that previously between ID and hepatologist with the interferon and ribavirin. And interferon was injectable, had a lot of side effects, and both ID and hepatology managed that. In addition, I also want to point out to the IBD drugs. IBD drugs, they have, which you can think about the FGF21s. The IBD drugs, they have antibodies issues, they have injectables, they have side effects. And the GI docs, actually, they're used to it as well, or most of them are. Or at least, like, eventually, it could be, even within GI and hepatology, the management could be separated in two tiers, like first-line NASH drugs, that they are easier to use and could be less efficacious, and eventually, like, more efficacious NASH drugs that they just refer if they are not having any response to hepatologists, and we manage. I don't know. I'm just making that up on the go, but there are multiple possibilities that the future can bring.
So with all that, thanks for your time this morning. And I'd love to have you over the next month. We're going to be reviewing what's been a remarkable month. I mean, I think everybody came out of EASL with their head spinning. There was just so much there on so many different dimensions.
Yeah, indeed.
One of the episodes from EASL, someone described it as a coming out party for Yale and IT, something I know near and dear to your heart. And that's all about non-invasive testing, having nothing to do with drugs per se, except since we're talking about in this conversation. There's going to be a ton over the next month as we talk about everything to digest from EASL and with an assist from San Diego. But I think this conversation and the one or two others I'm going to have today will be great in giving people just a broad sense of understanding what we can be confident we do know versus what we don't know yet, but we're really going to be excited to learn versus what we haven't even figured out how we're going to learn yet. Thanks for your time this morning.
Good to have you, especially like surfing the tsunami is my first thing coming back from almost 2.5 weeks being away. So it's good to start the week like that.
Thank you. And then I'm going to ask you my favorite question right now, which is, we have to change our name because everyone tells me NASH is dead.
My name is Mazen now.
So just to give a little hint, the interesting thing about Mazel is it sounds like muscle, right?
Yeah, so we're debating that, and there is a task force. So as you know, it's going between Mazel and Masled, and I think we're leaning more toward Masled, but of course people will name it differently. So it's Masled and MASH. We're having too much fun in this field.
I know. And in the middle of that, we're learning a whole bunch of stuff at the same time. Thank you for your time today, my friend. I look forward to talking to you soon. And
absolutely.
Okay. Bye-bye now.
Bye.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingnash.com. Next week, we'll be back with Stephen Harrison to discuss some of the major drug development stories of these two sessions. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.